Hello, and welcome to this PrecisCa mini breast tumor board on breast cancer. My name is Dr. Reshma Matani. I'm a breast medical oncologist at the Sylvester Cancer Center, University of Miami, where I co-lead our breast cancer program. It's my pleasure today to be joined by several well-renowned breast experts who I will now ask to introduce themselves.
Good afternoon, everybody. I'm Dr. Maxine Jockelson, and I'm the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am a breast imager.
Hi, everybody. Ruth O'Regan. I'm the Chair of Medicine at the University of Rochester Medical Center, and I'm a breast cancer medical oncologist.
Hi, I'm Chirag Sharma, a radiation oncologist. I serve as Director of Breast Radiation Oncology and Clinical Research at the Cleveland Clinic Taussig Cancer Institute.
Hi, I'm Terry King. I am the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center.
This is a 50-year-old woman who was recently diagnosed with metastatic right invasive ductal grade 2 ER positive, PR positive, HER2 negative disease, status post right modified mastectomy following neoadjuvant letrozole. And the question is posed with regards to further management. Her initial presentation was that she presented with an enlarging right breast mass with 2 skin lesions, performance status of 0, type 2 diabetic, GYN history is shown, no toxic habits, no family history of breast or ovarian cancer. And here is her initial presentation back in July of 2020, grade 2 invasive ductal carcinoma, ER 90%, PR 5%, HER2 negative. Her mammogram and ultrasound are shown, or her mammogram results include a 8-centimeter right breast mass with 2 skin nodules and diffuse skin thickening, along with a right axillary mass. The chest, abdomen, and pelvis CT shows a right breast mass and enlarging nodes in the axillary, retropectoral, internal mammary, mediastinal, hilar, and supraclav nodes, along with indeterminate pulmonary nodules. Dr. Jockelson, if you wanted to make any comments on the imaging.
Sure. Unfortunately, I don't have all of the windows appropriate for this, but what we do have are several images from a chest CT, and what they demonstrate, and so you see 2 of the breast, and you see some skin thickening on the upper image, and then a very large mass in the outer portion of the right breast. The subsequent images are from more superior, and you can see that there is large right axillary disease, and disease extending both levels 1, 2, and 3, and probably supraclavicular disease as well in the images all the way over on the right.
Mm-hmm.
And apparently there was also was she the patient who also had a PET? Yes. And there was no uptake in the lung nodules, but any lung nodule that's under a centimeter falls below the resolution of PET. And although sometimes you can see uptake, the fact that there's no uptake does not exclude metastatic disease if these are small lesions.
Mm-hmm. So as stated, the biopsy of a right axillary nodal mass in August of 2020 showed metastatic carcinoma. A left supraclavicular lymph node was FNA'd. Metastatic carcinoma PET scan, as Dr. Jockelson just mentioned, showed uptake in the right breast and right axillary nodes only. And she received letrozole as therapy for 6 months, and then had a restaging CT that showed a response in the breast, resolution of the right axillary nodes, and reduction in resolution of the supraclavicular nodes. The pulmonary nodules were indeterminate and were felt to be stable. And then she undergoes surgery. And there is 1.8 centimeters of grade 2 invasive ductal cancer noted with negative margins, 8 of 8 positive axillary nodes with lymphovascular invasion and extracapsular extension. So as we discuss the further management of this patient, Dr. O'Regan, I'll start by by asking you, the patient, when she initially presented in August of 2020 with enlarged mediastinal hilar nodes, indeterminate pulmonary nodules, but was really treated with more of a curative intent approach. How are you viewing the patient now? Is this someone that you would consider almost as a first-line metastatic patient and utilize the CDK4/6 inhibitor?
Yeah, I think that's a very good question. I mean, there's a couple of instances about this case. So, you know, I mean, she's pretty young, and you know, it was interesting the choice of letrozole, but it sounds like she was postmenopausal. The fact that she got a response from letrozole obviously would suggest that she was, but certainly, obviously, you need to be very cautious about that. I think since she was clearly metastatic at diagnosis, I probably would have thought about a CDK inhibitor at that time point. At this point, however, given the fact that she has responded pretty well to the letrozole alone, I'm not sure whether I would add one in, but I would certainly consider it because I think, you know, she has documented metastatic disease, and that really is the standard of care. And she does appear to have endocrine responsive disease. So I think adding in a CDK inhibitor certainly would make sense in a patient like this. I would not give her chemotherapy because she has metastatic disease, but I think adding in a CDK inhibitor would make a lot of sense in this scenario.
Mm-hmm. Dr. King, is this someone you would have operated on?
I personally would not have. We do not have any level 1 data that supports the role of surgery in de novo stage 4 breast cancer. There's multiple, you know, well, the best trial now, the ECOG 2108 trials reported out by Dr. Khan at ASCO last year, with absolutely, you know, no survival benefit in overall survival or progression-free survival with the use of surgery in the setting. And those were patients who were treated with systemic therapy first, and those that had, you know, either a good response or stable disease were then randomized. So this patient would have absolutely fit into the characteristics of the patients on that trial. I think it's, you know, there are still some people hoping that we will identify a subset of women that will benefit from surgery in this setting. But really, I think all the data points to being responsive to systemic therapy and continuing on a systemic therapy that provides durable control is much more important for these patients than surgery is.
Mm-hmm. So Dr. Schaaf, she came to you after a surgeon operated on her, and you were asked, would you keep going with that approach in terms of an aggressive local regional strategy? Would you offer her radiation?
You know, it's
started down the path, right?
Yeah, it's the tough question. So, you know, to Dr. King's point, if surgery is not associated with survival, then clearly post-mastectomy radiation will not be associated with survival. So I make that very clear to the patient. But part of the challenge is once you've gone halfway down the road, I don't think you encompass all of our initial sites of disease safely. That being said, with 8 of 8 axillary lymph nodes, LVSI, and extranodal extension, I might offer a short course of radiation to the chest and lymph nodes purely for local control to avoid, you know, a local recurrence. Obviously, I would make it more important that the systemic therapies are there. So if she's taking, you know, letrozole or letrozole and a CDK4/6 inhibitor, we can give radiation therapy concurrently with that, and that would be at least a discussion with the patient.
Great.